Okay, well, welcome to Mental Health Advance Directives with Nirmala Dhar and Dr. Andrea Avila. And we're going to go ahead and get started. So we're asking you to mute your microphone. We are going to utilize the Q&A box for questions or comments or the chat. Either one is fine. I think we have both of those available to you. Slides are going to be sent out to you. And we also are going to be posting this training on our older adult YouTube channel. But live attendance is required to receive the 2 CEUs. To claim your CEUs, you will be required to complete a survey, and that survey will be sent out within 2 weeks after the ending of this training. And then if you would be gracious enough, PSU does our evaluations, and so they will be sending out a survey as well, where you can receive a certificate of attendance, and that lets us know how we are doing, and if there are any topics that you would like us to bring to you for a training, please add that. And so give us about 2 weeks. Usually we're quicker than that, but a nice 2-week buffer for us to send you out those different surveys. So the Behavioral Health Initiative is a statewide initiative in Oregon that started in 2015, and we work to meet the needs of older adults and people with physical disabilities by improving timely access to care from qualified providers. And we have 24 specialists across the state within different systems of care, usually either Area Agency on Aging or the Community Mental Health Program of each county. And we do collaborations, coordination. We build knowledge through workforce development trainings like this, and then also providing community health and wellness education. And we also are available to do complex care consultations. So if you do not know your specialists, please reach out to them, because we are a very good resource for folks. And you can find out who's in your county at the OregonBHI.org website. Okay, so we are first going to start off today. We have 2 wonderful presenters. Our first presenter is Nirmala Dhar, and Nirmala Dhar is a licensed clinical social worker with a master's in social work from the Brown School of Social Work, and also Bombay University in India. She's mission-driven and has a passion to work with the most vulnerable clients, often with cross-sector complex care needs. Nirmala has worked for 36 years in all aspects and programs of behavioral health in the public sector in Missouri, New Jersey, and Oregon. She's a senior policy analyst and the Older Adult Behavioral Health Services Coordinator for Oregon Health Authority's Health Systems Division. And in this position, she is the Older Adult Behavioral Health Initiative Project Director, the PASSAR Level 2 Coordinator, and the Subject Matter Expert for OHA. She is the Project ECHO Geriatric Behavioral Health Champion at the OHA, and she helped created the first nursing home ECHO on the West Coast in 2018. And prior to the position that she's currently in, she worked for Clackamas County Behavioral Health for 18 years. This included 10 years as the geriatric mental health specialist for the county. She's provided lots of trainings on a variety of topics over the past 20 years. Her areas of professional interest include healthy aging, social justice, workforce development, quality improvement, health metrics, intersection of law and mental health, and service delivery innovations. Nirmala lives in Lake Oswego with her husband, Sanjay. So we love bringing Nirmala to do these trainings. And we're going to start off with a survey. And this is going to help Nirmala and Dr. Avila be able to get to know you guys a little bit more. So let me move a box around to get to it. Okay, so with this survey, you have to scroll down. So it's more than just the first one. So scroll down and answer. I think there are 5 questions.
And Angela, you'll just display the results, correct?
Yeah, we're almost there. We have almost 70% have answered.
Okay.
Okay, so I'll go ahead and close out the poll. We're at 75% or 90%.
That's a good, yeah, that's good.
We're at 90%. Okay, so sharing the results.
Okay. So now I can't see number 1. Let me go up then. Okay, the majority, it seems, are the biggest group here are case managers, I see. And then, everyone else is also represented there. QMHAs, QMHPs, social workers, primary care. So very good representation. Community health workers, RNs, managers, and others. Do you work with clients who have serious mental illness? Wow, almost all of you, 95%. So you're at the right training. Does your workplace provide information or education on mental health advance directives to your clients? And it's a mixed bag. I mean, almost half say yes and half say no. So there's some work to do there. And then within the last 12 months, have you taken a training on this topic? And the majority have not. 95% have not. And then how comfortable are you explaining Oregon's advanced care directives to your client or to a client? Yep. And 43% say they are somewhat comfortable. And the majority say that you're not comfortable. So I'm glad you're here, all of you. So thank you. I recognize lots of names. So people who know me, thank you for joining us. And I'm delighted to be presenting this training with Dr. Avila. We are going to complement each other. I do want to acknowledge that some of my slides in the latter half, or actually the last quarter of my presentation, were taken by a presentation provided by Jan Friedman, who is a senior staff attorney at Disability Rights Oregon in 2022. Next slide. And so my part of the training, I'm really going to look at the history of how did we get where we are in terms of advanced care directives in general, and in particular, mental health advance directives. And then I'm going to identify what the Declaration of Mental Health includes or covers. That is the Oregon version. The second speaker will also be somewhat addressing bullet number 2. So welcome again. And Angela, if you just want to move on to my slides. I want to begin with the story. And this is really a cautionary tale with a great ending. And many of you who worked for many years in the field, like I have, will absolutely recognize people that you worked with. So doctors diagnosed Jane with a bipolar disorder after a severe manic episode that lasted for several months. She experienced racing thoughts, very high energy. Family and friends struggled to understand her. She spoke like rapidly, disjointed or tangential thoughts. She began having delusions about herself and others, believing that she was reincarnated as the savior. And then she began to perceive good and evil in strangers, that she could just read their face and let them know that they were good or evil. Her family tried to admit her to a psychiatric hospital. How many of you have experienced that, where you work with families who are crying at your doorstep for help? They tried valiantly to admit her to the hospital, but staff refused to keep her because she refused to accept treatment. And she was technically not in danger to herself. Through it all, Jane believed that nothing was wrong with her. Instead, she was exuberant, and that she kept talking about, hey, I've discovered the secret of happiness. As her bipolar disorder progressed, she cut off all contact with her family and friends because they could not appreciate her newfound happiness. She befriended criminals on the street, allowing them to stay in her apartment, buying them expensive presents. She stopped going to work. She rarely slept. Eventually, she obviously ran out of money. She was also financially exploited. She became homeless and wandered all over the city, talking to anyone who would listen to her, frequently picked up by police, in jail a few nights. After devastating nearly every aspect of her life, Jane's delusions started crashing down around her, and she was alone with no money and no support. Next slide. Her family agreed to help her if she sought treatment, as they had maintained all along, and Jane finally agreed to be admitted to an inpatient treatment program. After recovering from the episode, declaring bankruptcy, rebuilding relationships with her family and friends, finishing college and returning back to work, Jane decided that she never again wanted that illness to control her life. Unfortunately, she knew it was likely that if she became manic again, she would experience that same loss of judgment and insight, or we sometimes in clinical term call it capacity, that had prevented her from seeing truth about her condition the first time. She now followed her treatment regimen. She worked collaboratively with her treatment team. She was taking medications, but she always had this nagging fear at the back of her head. What if that happens again? And then to quell her concern and fear, she executed a psychiatric advance directive, a legal document that enabled her to plan her mental health treatment in advance. In Jane's case, she gave prospective consent for hospitalization medications for future manic episodes. So keep Jane in mind as we move through our presentations today, and we'll have some time to discuss ethical dilemmas, which are often raised, in these kind of instruments. So keep those thoughts, write them down. And so I'm going to move on to the next slide. So I'm going to walk you through a quick history about where, how, and why, and where did these advanced care directives come from, and so that you have a clear historical context of the point in time they were developed and why were they developed. So very quickly, the first advanced directive was proposed by the Euthanasia Society of America in 1967 by a human rights lawyer from Chicago who represented that society. And he described this kind of concept in a article in 1969. And he began with the common law and constitutional premise that the law provides that a patient may not be subjected to treatment without his consent. All of you who work in mental health or in medical or healthcare settings, the very first session when we meet people, we ask them for informed consent, right? They have to sign a form. So that's what he was arguing. The challenge was what to do about patients who no longer were able to make healthcare decisions, but they needed maybe hospitalization. He suggested that the individual should indicate in writing ahead of time the extent to which he or she would consent to treatment or any kind of treatment. And he was the one who first referred to this document as a living will. Technically wills are, after you die. So this was while you were alive, you were writing this declaration. And so he was the one who first started calling it a living will, a declaration determining the termination of life or a testament permitting death, among other things, So that is kind of the genesis. I'm sure there were discussions way before 1967, but this was the first article that came out, and there was a public conversation about it. Next slide. And so, keeping that in mind, anyone knows Nancy Cruzan? Here is this kind of lovely young lady. She, looks pretty unassuming, but she had one of the most profound impacts on this initiative of advanced care directives. She was 33 years old, married, and was driving to work one day where she was in a devastating automobile accident where her car, rolled down an embankment. She was actually ejected and thrown out, and basically went into a coma and vegetative state. She was 33 years old at that time. And she remained in a coma for 8 years. And it is her case and her family that brought this landmark right to die case that went all the way up to the Supreme Court. She eventually passed away in December 1990. Her parents had to go back to a lower court, and you will hear the history. And she passed away based on their intervention. But I want you to remember Nancy and what a profound impact she had on this movement. And really, her parents, despite their pain, that is their purpose now, that her life made a difference in the lives of millions of people based on the Supreme Court decision which came out of her case. Next slide. So with this little backdrop, I want to kind of point out that the history of psychiatric advance directives kind of paralleled the development of medical advance directive for end-of-life planning. So they were kind of going along parallel paths. The original advance directives were born out of this Supreme Court decision that I was alluding to in Curzon versus Director, Missouri Department of Health. So it was Nancy Curzon's parents who had brought this lawsuit. And what was the decision? That decision said that clear and convincing evidence of a patient's preference was required for removal of life support. Remember, I said she was comatose. Not only was she comatose, she was in a vegetative state. That means she was essentially brain dead. And her parents sought to remove the feeding tube. By that time, the parents had worked with getting her divorced, so her husband was not making the decision. So the next in line was parents. So they wanted to remove her feeding tube, but the state would not allow it. They would not allow them to make that decision, given that their daughter was quote unquote incompetent. She was vegetative and comatose, and that there was no clear evidence of her wishes regarding life support. I mean, nowhere was it written or recorded or anything. So the Supreme Court decided in favor of Missouri Department of Health. That means they said, nope, you cannot remove the feeding tube because the client, the person is incompetent to make the decision, and we don't see any kind of evidence that she wanted you to do this. This case spurred interest in the expansion of living wills and medical advance directives. Shortly after this decision by the Supreme Court, we get the Patient Self-Determination Act of 1990, which operationalized advance directives by requiring hospitals receiving federal assistance of any kind to ask patients if they had an advance directive or would like one, and to give them information of how to create one and how to honor it. So, as you can see, Nancy played a crucial role in this. Next slide. So I've told you about the Supreme Court decision, which is pivotal in the development of this movement. The court recognized that people who were competent had a right to refuse treatment as the doctrine of informed consent. Remember, we ask people for their consent for any kind of treatment. So the court is recognizing that actually in the Supreme Court decisions. For decisions to be made on behalf of incompetent people, and by that, it's a legal term, okay? So it's not derogatory or anything, it's a legal term, which means that a person is unable to make decisions for myriad of reasons. So on behalf of an incompetent patient, the court requires, what's the standard? Clear and convincing evidence that the patient would want treatment terminated. So this is your advanced care, okay? They said we should see clear and convincing evidence that Nancy or anyone like Nancy wants treatment to be terminated. In her case, it was actually removing her feeding tube and her ventilator. And what the court decided in Nancy's case was to err on the side of life, where what was at issue was not Nancy's right to die. That was not the argument, but the right of others. Can others take her life, like her parents? And the opinion was Nancy is not dead. She's like at this point 8 years there after the automobile accident, nor is she terminally ill. I mean, that could be argued, but that was what they said. So this is a case in which we are asked to allow medical professions to make Nancy die by starvation and dehydration. The debate here is not between life and death, it is between quality of life and death. So in the majority opinion in this landmark case in 1990, the US Supreme Court broadened the ruling of Missouri Supreme Court, though it still did not grant Curzons the victories that they wanted, which was to remove the feeding tube. However, the court recognized a competent person's constitutionally protected right to refuse life-prolonging treatment, including hydration and nutrition, if that is your wish. In the case of an incompetent person like Nancy, a state should adopt a standard that requires clear and convincing proof of that person's preference. And there is the genesis of this movement, that we are going to explore. So I know this was a little bit, there were some legal issues here, but it's very important for you all to understand where this is coming from and how this kind of movement developed. Next slide. So again, I'm just reiterating how important this decision was. The court said that people who are competent have a right to control their medical treatment. Like you and I, all of us here on this training today, in 1990, we would be say, hey, we are competent. I can say, nope, I don't want this treatment. Yes, I want this treatment. So that was absolutely recognized by that court in that decision. And that competent people have a fundamental liberty interest in refusing unwanted medical treatment. You can't force me to take any treatment. It's my constitutional right. However, in Curzon versus Director, Missouri Department of Health, the Supreme Court found that where the prior expressed wishes of an incapacitated person, such as Nancy, or someone who has periods of incapacity, I'm adding that's not what the court said, can be determined by clear and convincing evidence and then those wishes should be honored. That was also in the decision. So implicit in this decision is the right of patients to provide explicit instructions, clear instructions concerning his or her future medical care during periods of incapacity. Again, I want to say that again. Implicit in this Supreme Court decision is the right of a patient to provide explicit instructions concerning their future medical care during periods of incapacity. Now think of Jane. The Supreme Court has since affirmed its implication in Curzon, finding that the right to refuse unwanted medical treatment is so rooted in a history and tradition and practice as to require special protection under the 14th Amendment. And I'm not really going to go in the 14th Amendment. If anyone is interested, I will be happy to send Angela some links if you want to read more on the relevance of the 14th Amendment in this particular context. Next slide. And so what happened after this decision? Less than 1 year after this Supreme Court decision, New York State recognized that a person's fundamental right to refuse medical treatment extends equally to people with a serious mental illness. That means that we are talking about like 1991. So it's been around, a while. Further, giving that concept of executing an advance directive is centered on the contemplation of future incapacity, mental health advocates began to make the logical argument that advance care directives are well suited for people with serious mental illness. That means you're contemplating future incapacity. Now, think about Jane again. Because mentally ill patients often experience cyclical periods of competency and incompetency, I'm a clinician, we call it decisional capacity. So it fluctuates depending on, your illness. Advanced directives would afford these patients the ability to better control the course of their treatment. So they could predict, hey, future, if I were to get get into a kind of a psychotic relapse or, something happens to me, this is what I would like you to do. Most advanced healthcare directive statutes allow individuals to make decisions regarding future mental health care. So that's kind of right after Curzon, the decision that this topic came up. Hey, this also applies to people with mental illness. Remember, Nancy's case, it was really medical. Next slide. So remember I said these are parallel developments. So absolutely, while the Medicare advanced directives were being developed, so was this national debate on psychiatric advanced directives. And really, the argument was that they are a mechanism to facilitate engagement of persons directly in their own care in times of incapacity. Next slide. And so this is what happened. After Curzon and all of the national debate, the Patient Self-Determination Act was passed, rooted in the belief that people should be given information that enables them to specify the extent of medical treatment they wish to receive, should they become incapacitated. How many of you currently, I go to my doctor, I was with my dentist the other day, and they clearly discussed, Nirmala, you have this options, and I turned down all of them. I had that right. I said, nope, I don't want any of them. So essentially, it's that patient's right for self-determination, which should also extend to when you're incapacitated. And so the Patient Self-Determination Act was signed into law as part of the Omnibus Budget Reconciliation Act of 1990, and marks the first time that Congress passed legislation concerning the ethics of life-sustaining medical treatment. And by the way, the bill was spearheaded by Senator John C. Danforth, who had a special interest. He was also an Episcopal priest and a former assistant chaplain at New York's Memorial Sloan Kettering Cancer Center. So he brought a lot of his personal and professional experience to this, and he was the one who spearheaded this act in Congress. Next slide. And by the way, I have a keen interest in Senator Danforth, because the Danforth family are very prominent in Missouri, and actually, the university that I attended, Washington University, is heavily endowed by them, and many of them are, part of the university. So yes, Senator Danforth. So again, with all of that backdrop, these were the two significant developments in the legal landscape, which generated this interest in psychiatric advance directives. I've already just told you about the Patient Self-Determination Act, which was introduced in 1991, which set new federal requirements intended to implement advance directive policies at all healthcare facilities that receive federal funding. I know I've gone with family members who have been admitted to the hospital, and part of the intake, they ask you, do you have advance care directives? If you don't, they give you like a copy of the living will to create. That is required by law. So that was the first one. But the second motivating force behind the rise of psychiatric advance directives in more recent years has been the intense reaction in some quarters against policies of legally mandating psychiatric treatment, particularly outpatient commitment policies. And now this has come again to the fore with our national crisis in forensic, national crisis where people with serious mental illness are now, ending up in jails and prisons. This kind of discussion has again come to the fore. But really, so also this reaction to, hey, we don't like being mandated into psychiatric treatment. That also spurred this kind of interest in creating psychiatric advance directives. So those were the two big legal significant developments which influenced kind of this burgeoning interest in the development of psychiatric advance directives. Next slide. And so the important development was that PADs, or psychiatric advance directives, appeared to be a very positive alternative. The possibility of patient empowerment and beneficial treatment, so that patients could be empowered to say, I want this, I don't want this ahead of time. In theory, a PAD and the process of preparing the psychiatric advance directive, while competent, could facilitate engagement in treatment process, help mobilize clinical resources, because the person would have to put in what they want, what they don't want, so they kind of know the resources. Maybe improve adherence to therapies if that is indicated for their particular set of symptoms, facilitate communication among providers, caregivers, and patients, and thus help to avert psychiatric crises. That is really the bottom line. But we'll talk about, some of the shortfalls. Next slide. And then along came CMS. CMS stands for Center for Medicare and Medicaid Services, which is the big federal agency which regulates, healthcare and funding and billing and all that for healthcare. So in 2006, CMS made it clear that psychiatric advance directives should be part of psychiatric care in their publication of their final rules on seclusion and restraints. And this is straight out of the Federal Register. The patient has the right to participate in the development and implementation of his or her plan of care. The patient or his or her representative has the right to make informed decisions regarding their care. The patient's rights include being included in care planning and treatment, being able to request or refuse treatment, and then the patient has the right to formulate advance directives and to have hospital staff and practitioners of all kinds to provide care in the hospital that complies with these directives. And that the patient has the right to have a family member or a representative of their choice and their own physician notified promptly of their admission to the hospital. How many of you have struggled when families have tried to ask, is my son with, in this program, is my son in the hospital, and, HIPAA rules, others, we can't tell them. Often to great deal of detriment. But this now allows that a notification of the representative of the person's admission to the hospital or family member, whoever is selected on the form. Next slide. So what's the difference between psychiatric advance directive and medical advance directives? I know Angela has provided some great trainings on medical advance directives. I mean, we just call it advance directives. But what's the difference? The psychiatric advance directives differ from medical advance directives in several respects. What we call living wills and just medical advance care directives require thinking forward to a future state that a person has never experienced. For example, say dementia. I may be 70 and I want to write an advance directive. I may have some risk factors. So I'm thinking maybe at 80, I may get incapacitated with dementia, or could be Parkinson's disease, which can also lead to a dementia. So it's a future state. So the person that you have never experienced before. While the PAD, which is psychiatric advance directives, is often based on past experiences, that you're writing that based on your past experiences. While medical is future, which you have never experienced, but you're anticipating it. So a psychiatric advance directive serves as a kind of self-prescription, like you're prescribing it for yourself, that binds the person to decisions made in advance. So once you put it, it is a legal document. It's binding. And by the way, I'll talk about it a little later for 3 years. So you're kind of saying, this is what I want, and it's then binding. This aspect of psychiatric advance directive should be clearly described to the person who is interested in creating one. Because once a person is deemed incapable, or what we talked about, incapacitated, the PAD is not revocable until the person regains decisional capacity. So in the middle of a psychotic crisis, Jane could not say, oh, I'm going to revoke my psychiatric advance directives, because it's based on her ability to make that decision. And so this needs to be very clearly explained to the person if you are someone who's facilitating or helping them develop a psychiatric advance directive. First of all, it's based on their past experiences with their illness, and that once created, it is a self-subscription which they will follow through, and there are some limits which we'll talk about, and that they cannot revoke it until their capacity is restored. Only then they can revoke it. Next slide. So what are these PADs, or Psychiatric Advance Directive? It is a mental health advance directive. It's a legal tool. So very important, it's a legal tool, just like the medical advance directive, that allows a person with a mental illness to state their preference for treatment in advance of a crisis, just like in the medical advance directive. They serve as a way to protect a person's autonomy. That was really the underpinnings of that, patient self-determination act, was autonomy and control. And so having a PAD protects your autonomy and your ability to self-direct your care when you're unable to, because of the nature of your illness. Now think about Jane. She went into long periods of time when she was incapacitated by legal and clinical, evaluations. They are similar to living wills and other medical advance directive documents used in palliative care. So remember, parallel, similar, same legal authority, but we will look at some of the limitations. Next slide. So the key term here is, when you are working with people, is that it really comes out of this movement for self-determination, which wants to protect people's autonomy and control, that you are making these decisions when you're capable of making them. Because the nature of your illness is that it can be cyclical. So what are the mechanics? So they have two parts, these advanced directives. So first part is instruction and a healthcare power of attorney. A person who wishes to develop a PAD can use one or both parts. So the first part, the advanced instruction, you can detail preference for treatments, give consent for admission, consent for contact in advance. You can give detailed preferences for medications or treatment modalities. You may say, I don't want this medication, but I want this medication because I've done well on it. Some people say, I don't want electroconvulsive therapy if I'm very, very depressed. Some say yes. So you can put any and all of it, as much detail as you want in there for your preferences. And refusal, I don't want this. You can also give instructions on practical matters, such as childcare, contacting your employer. You're giving permission to your healthcare representative, you can take care of my kids, or call my employer, let them know that I'm in the hospital. The healthcare power of attorney can be used for medical, in this situation, medical and psychiatric emergencies. And basically, you're appointing a trusted individual to serve as your healthcare agent, just as in the medical advance directives. And you're giving them decision-making authority during the time when you are unable to make those decisions because of incapacity, which is the case in the medical advance directives. Next slide, please. So when does it go into effect? So once you write it and it is executed, it goes into effect when the person is found to lack decision-making capacity. A treating physician, psychologist, others can make that decision about capacity based on how that person is presenting in the community, or for some kind of examination, or in a court of law. So Some examples of periods when a person may lack capacity they include acute psychosis, extreme mania like we saw in Jane, catatonia, delirium, which could be kind of a mix, and obviously unconsciousness, coma, which can happen to people with serious mental illness too, but that was the case of Nancy. Hers was a permanent vegetative state. So it goes into effect when any of those things happen and you are incapacitated. In a crisis situation, if a person has been deemed incapable, the Psychiatric Advance Directive goes into effect, and treating professionals can refer to the PAD to get a clear description of the person's preferences for treatment, who to contact, and how best to support the person in crisis. So that's when it goes into effect. Next slide. How do you communicate that you have an advance? If you don't communicate it, it's futile, right? Nobody knows you have one. So once it's created, there remains the question of how its presence is communicated to a variety of people. And there are really also practical issues around storage and retrieval of these PADs. Where do you store it? How do you retrieve it in an emergency? Because remember the nature of the illnesses, you are incapacitated because of maybe mania or psychosis. How will professionals know that it exists? Ideally, they should be incorporated into your health record. Many of you, I saw some of your names work for community mental health programs, like certainly both the Angelas who are hosting this work for a community mental health program. How about having that as one tab in your electronic health record? That the minute you're notified, hey, your client is in the ED, or a civil commitment investigator or mobile crisis team is going out to see them, you at once pull up the PAD and communicate to the team, it's here. So, but that would be ideal. But let me tell you, it's not happening. So that it can be shared across healthcare and other systems. That would actually protect the client in crisis. So it's not operational, that's the aspiration. A person who completes the PAD may want to share this document with multiple sources and people, your outpatient providers, the local hospital system where you probably would go if you were in a crisis, your crisis responders like EMS or law enforcement, maybe your managed care organization, they have care coordination teams, they have a copy of it. Why? To make sure, not that they want to be nosy or interfere with your lab, but to make sure that the PAD is available when it's needed. Oregon has not, but some states have created secure repositories where you can go and upload the Advance Care Directive, and various professionals can go and do a search when there is a crisis to find, hey, is there a PAD on this person? So absolutely, how to communicate it is key, and that in most states, this legal document, when it is executed, has to be witnessed and notarized for it to become a legal document. Sometimes people say that is a barrier, including who can be a witness, but I think we can work around that if we wanted to promote autonomy and control for our clients. Next slide. So what are the benefits? Again, promotes autonomy and empowerment. That was really at the heart of the legislation. Enhances communication when you are a patient with your doctor, your team, and your family. Protects against ineffective and potentially harmful treatments. Helps prevent crises situations and reduces the use of involuntary treatment or measures such as restraints and seclusions. And aside from involuntary treatment, now, people who are deemed incompetent when they are picked up by law enforcement are mandated to the state hospital under aid and assist for restoration of capacity. We can bypass all of that if the person has a psychiatric advance directive. So really, I want to emphasize that the piece about autonomy and control and empowerment. Next slide. And the limits are, it does not allow the signer to avoid legal processes such as civil commitment and emergency hold. So it trumps it. Legal, civil commitment and emergency holds can trump a declaration of mental health.
Nirmala, this is Angela Jensen. Just wanted to give you a heads up on the time.
Okay.
We're coming up on 10.
Thank you. The declaration cannot force a doctor or other mental health provider to provide treatment that would be deemed inappropriate for the signer, even if they've put it in their advanced care directive. If it is inappropriate, the doctor or team can override it. It is only effective if people know that it exists. If it does, so that's the limit. We don't have any kind of statewide repository where we can go look it up, nor are we doing huge campaigns on education and awareness. So let's give it out. So it's only effective if we know it's there. And that the declaration of mental health treatment does not provide guidance for other types of mental health emergencies. So it's only for mental health. So those are the limits. Next slide. And I know I have about 10 minutes to cover this. And Dr. Avila may also repeat some of this just to kind of reiterate our learning today. So in Oregon, it is called Declaration of Mental Health Treatment, DMHT. And it is defined in these Oregon revised statutes. And it's actually been the law since 1996. So very soon after the Patient Self-Determination Act was signed into law. Next slide. Again, I've emphasized that it is a very important tool in a person's self-advocacy toolbox because it allows for choice and control, which is that underlying principle of self-determination and autonomy. It is a legal, very important vehicle that allows someone with a serious mental illness to choose what they consent to, what they do not consent to, what they would like to occur when they're in a mental health crisis. Someone may say, I don't want injectable medications. I only want oral. I'm just giving you an example. They can put that in their mental health advance directives. Next slide. Through this declaration, a person may choose if is something they want. If they choose to complete this document, it would be a plan for crisis, whom they want as their representative, whom they do not want, and to designate what's wanted, what they don't want, and what's important regarding their mental health treatments. Remember, this is based on past experience. So they kind of know what has happened to them in the past, what has worked, what has not worked. And so that's what they want to put into the advance directive. Unlike the medical advance directive, which is future, where you really don't have experience of dementia or what Parkinson's looks like in its final stages. Next slide. So again, it is a legal vehicle that allows people choice. And I'm repeating it over and over again because it's giving them a voice when they are in a mental health crisis, that they are putting it in writing. This is what I want when I cannot voice my consent or my preference. Next slide. So it really, the underpinning is that it gives agency and voice to someone in a crisis. The capacity of an individual to act independently and make their own choices, what I want, what I don't want when I'm incapacitated. And stability for a personally developed plan to be put in place. That's what Jane felt. She felt much more calm and at peace. Hey, I have this plan in place because I know my illness. It is cyclical. I know now what will happen if I go back into mania. I know the steps that my representative will follow. It won't devolve into homelessness. Next slide. So you can include any of this, patients can. Medications, doses, combinations of medications, preferred professionals, what kind of outpatient treatment they want or inpatient treatment they want, agreement on, or saying I don't want electroconvulsive therapy or something else. All of this can be put into the document. But remember, the limits is that a professional can override some of these interventions, but absolutely they can put that in their document. Next slide. So you can put in prescription medications that don't work. I'm just telling you, any allergies, types of therapies that you see have not worked for you in the past or have worked for you. So not just medication, you can even put in, the kinds of therapy modalities that you have particularly found helpful. So it can be as detailed as you want. Next slide. Is it moving? Are we frozen? Can everyone hear me?
I've got audio on you, and
I think we are back.
Okay. My presentation went offline.
okay. Well, it's live.
But no, the
So,
slide is no longer there. We
yeah.
are back to the gallery view.
Yeah, I see that.
Okay, I'm back. For some reason, it kicked me off, but we have started back up again.
Okay,
So,
yeah, you were frozen for a minute, yes.
yeah, so let me start to share again.
And I'm almost to the end, and we'll be handing it over to our second speaker.
Perfect.
And again, I'm giving you all examples. You will be getting the slide deck of what possibly people can write about, real detailed, what works for them, like what helps them, maybe it's a quiet room, less stimulation, while they're in a crisis, how they can communicate with them. It could be really to talk slowly to me or write down the instructions for me. So it can be as detailed as you want it to be. I would suggest the more detailed, the better. Next slide. And then you need 2 witnesses. That is sometimes considered a barrier. It is, that person is signed in their presence, appears of sound mind and is not coerced, not related by blood or marriage or adoption, the person who's a witness. And they can't be an operator of a facility where you're living or anything like that. Not a medical professional or, hey, I'm going to ask my case manager. And not the appointed representative. So you have to find 2 people, and it can be a barrier at times because you can see all the people who cannot be witnesses. Next slide. And like I said, if it's hidden under a rock, it does no good to the person, correct? We don't know what you want. It is best once it's executed to give it to obviously to your healthcare representative, to all of your mental health providers, to your physical health doctors, anyone else who crosses your path in a crisis. Maybe your local law enforcement or your EMS, or your ED, your emergency room. Absolutely. Because if they don't have it, it doesn't exist, especially in a crisis. When you are unable to tell them, hey, I have a mental health advance directive. Next slide. When can a person use this as a legal tool? It can be put in place when you're incapable. It's effective for 3 years. Remember, I said, and if capable, a person can revoke it. So you cannot revoke it in the middle of a psychiatric crisis. It can only be revoked once you have your capacity restored. Like Jane, she would get really well once she got the appropriate treatment. Next slide. When a person is civilly committed, the declaration of mental health treatment does not provide protection from coerced treatment. Even though you may have written there, it will override, supersede the mental health directive. You may have said, I don't want this medication, but if you're civilly committed, it goes into effect. Next slide. And what are the provider's duty? If presented with the mental health declaration, a provider must make that a part of a person's medical record. They must comply with the directive to the fullest extent possible. That's the operative word. A provider needs to have permission to administer medication that are not listed in a person's DMHT. So if, in case there is no one particular, you still have to take the permission of the representative. Can I use this medication? If it is not something listed in the specifically in the Advanced Care Directive. Next slide. And I'm not going to go over every slide of this, but basically, there are obviously some requirements and duties of a representative that basically you follow the desires of the person as articulated in the Advanced Care Mental Health, just like you the same kind of duties as you have for a medical advance directive. That is best interest. Next slide. This is less restrictive than guardianship. It allows for autonomy. We've talked about it, choice. It allows for individual liberty. There are many other less restrictive alternatives to guardianship, including supported decision-making, power of attorney, and then that medical advance care directive, but which requires both of them require competency when you're creating it. Next slide. And we can have this discussion later on in the Q&A. What are some ethical dilemmas that you are seeing in advanced care, in directives in general, but in psychiatric advanced care directives in particular? Next slide, please. And then really, part of this training that Angela's brought to us today was really an effort to increase the awareness of the value of psychiatric advance directives and how to use them effectively with people with lived experience of mental illness, their families and supporters, first responders, medical providers, peer support specialists, all of them. And that the mental health and emergency response workforce, whether it's mobile crisis, or it's our law enforcement or first responders, will benefit from trainings on actually knowing that this kind of document exists, and also on the practical applications of PADS. So Angela's, I would encourage you the next time to invite, adjacent healthcare professionals such as first responders, law enforcement, to also learn about psychiatric mental health advance directives. Because, at least, I don't know if in your other category, whether they were represented. Next slide. And here are my resources. I will send a link to Angela to share a practical guide to psychiatric advance directives. It's by SAMHSA. It's a wonderful document. And so I will actually post it as a separate link that you all, it will be in my slide deck too, but I'll also send it to Angela as a PDF. So you're welcome to take a look at it. And I thank you all. And I'm going to pass it over to our second speaker. Thank you, Andrea, for being patient. I'm all done now.
Great. So Andrea, if you want to pull up your slide deck and share, I will do your bio while you do that. So Dr. Andrea Avila is the supervising psychologist for the psychology assessment rotation for the Oregon State Hospital. Within that rotation, she supervises psychological assessments for diagnostic clarity, personality assessment, treatment recommendations, violence risk assessment, and cognitive impairments. She is also a certified forensic evaluator and periodically completes forensic evaluations at OSH as well as in private practice. Dr. Avila completed her PhD at the University of Nebraska-Lincoln in the Serious Mental Illness Research Group. She completed her internship with the OSH PIP and a forensic fellowship at Patton State Hospital. She has several published peer-reviewed journal articles, law review articles, and books, textbook chapters, as well as ongoing research project. She's currently serving as a co-chair for the 2023 APLS conference. Her interests include psychiatric advance directives, improving the utility and scientific rigor of general and forensic assessments, developing and testing comprehensive treatment services for people with SMI, and development of law policy that reflects evidence-based practices and a recovery orientation for people with SMI. And I think I might have missed in there that she is an attorney. You got your attorney credentials in Nebraska.
Yeah.
So you do have the law background as well.
I do. Thank you for that. Whenever you asked me for a bio, I guess I didn't think about it being read. It was kind of long. I should have shortened it for you. So I apologize. But yeah, my name's Andrea Avila. I'm so delighted that y'all are here today to learn more about psychiatric advance directives. In Oregon, the statutes, as Nirmala described, they refer to them as declarations for mental health treatment. And so I'm probably going to say DMHTs a lot, but that's what I mean whenever I say that series of letters. But yeah, I'm a psychologist. I'm also a licensed attorney. My background in psychology, like she said, I came up in the serious mental illness research group and then kind of cross-trained into forensics later. But my background and my passion is really about helping people with serious mental illness from a recovery orientation and a focus on like psychosocial rehabilitation. And so I'm going to talk about that a little bit and why that fits so well with DMHTs. I definitely come at this from a perspective of like disability is diversity and that our differences can be a strength. And I want to just kind of acknowledge I've used words like disability. I've also used words like serious mental illness for SMI, or sometimes I say SPMI, which is severe and persistent mental illness. There are lots of incredibly valid objections to using words like disability or severe mental illness, including concerns that it can make it sound as though people can't recover, that their prognosis is exceedingly poor, things like that. I would certainly never want to promote those ideas. And the law uses words like incapacity, disability, and so those are the words that get used whenever you're talking about legal things like this. And then also acknowledging the degree of intervention and the degree of support that's needed. I think we do need to have some language around that to identify the folks who are at the highest need for help and for support, and especially to stay in the community to the extent possible. So it's a bit of a dialectic. There seems to be a little bit of tension between those two sort of opposing thoughts of sort of using language that can reflect both the degree of need for intervention and also be supportive and inclusive for our folks. But if you're familiar with DBT, then you might be familiar with the idea that you can hold space for two viewpoints that seem to be opposing in the moment. Yeah, so that's kind of my psychology background. From the law side, I definitely got my law degree to support my interest as a clinical psychologist. So I'm a psychologist first and foremost. The law studies that I did focused really on disability rights and criminal law, because unfortunately, as I'm sure everyone knows, the increasing criminalization since like the 80s of people with mental illness, and especially people with serious mental illness, has been a profound difficulty. And one place where I've really gotten to witness that firsthand is working at Oregon State Hospital. So I've worked at Oregon State Hospital for about 5 years. And I was in FES for a little while, and now I work doing psychological assessments, which I really get to love. And just to note, obviously my views are my own, right? Like I'm not here speaking for the hospital or for OHA in any way, but they do support this work, and we've done a little bit of it at the hospital, and we're still trying to do more, but I'll talk a little bit more about that later. All right, so here are the learning objectives for today. I'm going to go over the research first, and then my very last slide is talking about ways to initiate this conversation. I really hope that learning how to use DMHTs as an advocacy tool and as for person-centered care has been kind of present throughout the training, right? Learning about the law, learning about how these things work, learning about the research behind them. These are all the things that you need to be able to be an effective advocate for the use of these tools for the folks who can benefit from them the most. All right. So before launching into the research, I have to emphasize that all of these outcomes, which are wonderful and lovely, only apply whenever a DMHT is used in the way that it is intended to be used. So Nirmala did an excellent job of really highlighting how these grew out of a movement that was intended to empower people with all kinds of disabilities, but especially people with SMI. And nothing about these tools, like the active ingredient of this intervention, the only way that you can expect it to work is if you're preserving those values that it was developed with in the first place. So if this is used in a way that is coercive, or if it's used in a mandatory way, then you are undercutting the entire point and the way that these can be effective. So DMHTs are intended to give people the ability to define in advance what they want for themselves. And that's really the most powerful aspect of it. So DMHTs are consistent with a recovery orientation, with self-determination, and with psychiatric rehabilitation. And I'm going to argue that those three things are kind of the main point of these and what makes them so effective. So I know some people might be familiar with those terms, but not everyone is. So a recovery orientation probably has about as many definitions as people who use the phrase. It's a phrase that's become exceedingly popular for wonderful reasons over the past couple of decades. But the central idea of a recovery orientation is that the hope is for individuals to be able to have a self-defined future that includes a fulfilling and productive life while adjusting to a disability that may be present. This idea is also consistent with psychiatric rehabilitation, which is a treatment approach to people with SMI that conceptualizes SMI as a disability to be overcome while emphasizing the development of functional capacities in multiple life domains to fuel meaningful and values-driven experiences. So I hope you can already see at this point in the presentation how these ideas are really compatible with using these legal tools to enforce someone's ability to make choices for themselves in advance. And I think one thing that's worth noting here is that if the individual does not have the capacity to make a healthcare decision, which is the thing that you need to have in place before DMHT becomes active, right? They have to be determined that they're not in a space where they can make their own healthcare choices. Even if they were at a provider asking for services, they would not be able to give informed consent to those services. So this is really about giving informed consent in advance. And then the last thing I'll touch on, there's already been a lot of conversation about self-determination, but the definition that I like to use of that is that it's the acknowledgement that the essence of being human is the right of people to choose all meaningful expressions of their values, including how they engage in treatment. So DMHTs are very consistent with that, allowing people to choose their own treatment, choose their own path forward, and choose what's meaningful for them. So starting to get into some of those research outcomes, the first thing that I'll note is that understanding DMHTs is associated with higher perceptions of autonomy a year after implementation for people who use these tools. So again, just very consistent with that perspective of giving power to the individuals who are going to be undergoing what would otherwise be involuntary treatment at that time. Generally speaking, most folks have shown an overwhelming preference to have a DMHT type document. And whenever I say an overwhelming preference, it's like above 70 or 80%, but few report having that document in place. So I think in this study that they did, the rates of folks who actually had a psychiatric advance directive in place were around 10 to 13%. So there's this huge discrepancy between people who would like to have access to a document to this and people who do have access to a document to this, like this. And we've already talked about a few of those reasons, right? There's not a lot of education about it. People don't really know that these exist. They became super popular in the 90s and the 2000s, but then just kind of died out for a few different reasons that I'll touch on in a moment. But now there's definitely a resurgence of interest in these, which I am just delighted to see happening. More recent research has shown that there's a reduction in compulsory hospital admissions, and there's a reduction in the use of coercive interventions overall for people who have one of these documents in place, which is wonderful because they're getting to define in advance what they want for their own treatment. Consumers, whenever they were surveyed about why it was so meaningful to have a document like this, gave a variety of reasons that were important to them, as you can see on the slide. The one of these reasons that always gets me is they wanted to be believed by providers, right? They wanted to have their voices heard and believed, even when they were in a psychiatric crisis, to have those wishes honored. They also reported that having the ability to be proactive and to be seen as a responsible agent in managing their experiences and the challenges that they faced was something that was incredibly important to them. So one thing to note here as well is that if a DMHT is on file with a provider and even if the individual who's come in has not been assessed to not have the capacity to consent to healthcare or to make healthcare choices, this can still be a document that backs up what the person is telling to the provider, right? Even if it's not legally activated, it's still there and available for the provider to review. And we all know that it is incredibly unfortunate, but that people with disabilities, people with SMI, and this also extends to other groups as well, people of color, women, sometimes they are not taken as seriously by their healthcare providers as other people are. And so having a document like this that has been sort of formally put together and that's on record and that there's some legal power behind, although I'll also talk about how unfortunately, some of these statutes don't have very much like teeth behind them. They don't have a ton of enforcement power, but having that there can compel providers who may otherwise be reticent to take someone perhaps a little bit more seriously whenever they're expressing the things that are important to them and how they'd like to proceed in their treatment. Okay. So completion rates and interest were positively predicted by clinician support. So anytime that there is someone who can talk to people about these forms and who can help them complete the form, we see completion rates go up. That's true for providers. And I don't know if I got this citation in here because it's relatively recent. It's also true with peers. So if you have a peer support program where peers can sit down and help someone complete a DMHT, it's more likely to be completed and implemented at that point. And I mean, that makes sense to me, right? If I have a bunch of things on my to-do list, especially something that feels kind of overwhelming, like putting together a legal document, if I have a scheduled time and someone who's going to sit down and do it with me, I'm far more likely to get it done all the way through. So that makes a lot of intuitive sense there. Oftentimes people are supportive of DMHTs and they like them as an idea, but there's not a lot of familiarity with it. People get a little nervous. They get a little nervous around the legal and ethical implications. It can be something that feels very intimidating, even to the providers as well. So that really shows that there's an opportunity for more education to increase the use of these documents. People like them, they like the idea of them, but it's just hard to do independently. When clinicians identified barriers, most of them were pragmatic as opposed to like ideological or an objection to the document itself. Things like they don't know where to find the document. They don't know how to find it, how to fill it out, how to execute it. And I did a little bit of research here in Oregon a couple of years ago, and I'll talk about that in a moment, but that really showed up in the research that I did a couple years ago. And I'd argue it showed up a little bit in the poll that we took at the beginning of this training, right? People, you're obviously interested in this idea, you're here. And it sounded like a lot of people didn't feel comfortable talking about them. And there was some lack of familiarity. So hopefully that will be changed by the end of the training. So another issue beyond like sort of pragmatic barriers is enforceability. Providers sometimes get nervous about taking on additional liability. And as Nirmala spoke on earlier, the enforceability is really that it has to be a good faith effort on the part of the provider. They can withdraw, a provider can withdraw if they have an ethical concern, or if, say, what the person is asking for is outside of their scope of competence or not something they normally do, they can refer the person to a different provider. And just like in-person informed consent, just because someone asks for something doesn't mean that the doctor's going to do it, right? So if someone goes into their doctor's office who has never even had a history of SMI, and they ask for something and the doctor's like, oh, no, you can't have that medication. It's contraindicated with one of your other medications, or it's contraindicated given one of your other healthcare conditions, then that's still a limit that the provider can, oh no, hang on. Did it stop sharing my screen?
We are seeing your
computer froze.
the back end slides. So switch to
Slides. Okay, hang on. I'm gonna try again. I don't know what just happened. There we go. Are we good now?
we are good.
What would a webinar be without some technical difficulties? Okay, so this is the slide I want to be on. So that's what happens whenever I talk with my hands and then my computer falls asleep. Enforceability. So there's a good faith requirement on that, but there's the same limitations to it as would be normally expected. So I just also want to draw in, I spoke a little bit a couple of minutes ago about how DMHTs reduce involuntary hospitalizations and other coercive interventions. And not only does that help the individual who has the document in place, but that also has implications for the well-being of providers and frontline staff. Providers and frontline staff, especially people who are coming from a recovery orientation, who believe in empowerment, who are very invested in the well-being of the folks that they care for, which I'm sure is the same for everyone here. Having these in place and reducing coercive outcomes helps to reduce the occasion of burnout and moral injury and possibly physical injury that can happen to the folks who are trying to provide treatment. And of course, I'm coming from a perspective of someone who spent a lot of time in psychiatric state hospitals working with folks. So this is about so much more than just one person having additional voice and choice in their treatment, even in moments when they normally wouldn't. It's also about helping everyone who's involved with the system, right? Their families, their loved ones. We heard a story earlier about an individual, hypothetical story, right, of someone who could have been really positively impacted by a DMHT. And ideally, this will hopefully also reduce the load on some of our systems like Oregon State Hospital, which ideally, if people could never be brought there, that would be great. So one thing that I do want to touch on about enforceability is this case called Hargrave v. Vermont. So this is a case that went up to the Vermont Supreme Court. And sometimes you'll hear folks who have concerns about the legality and the ethics of these documents, they'll cite back to this case. So what happened in this case was there was a woman who had a psychiatric advance directive in which she refused the administration of all antipsychotic, neuroleptic, psychotropic, or psychoactive medications and ECT. So she was civilly committed, and her provider sought to override her advance directive, and they were successful, and she sued after the fact that they had overridden her advance directive. And as this went up to the Vermont Supreme Court, essentially what they did is they looked at the statute that allowed providers to override the psychiatric advance directive. And what they learned was that the psychiatric advance directive under Vermont law was easier to override than a physical or a healthcare advance directive. And the Vermont Supreme Court said, that's not fair. If you're going to have a law that says how to override an advance directive, it needs to be fair across types of advance directives. You need to have the same protections for people who have a psychiatric advance directive as you do for people who have a healthcare advance directive. And they said that they applied the 14th Amendment, which has been talked about a little bit here today. And they said, this is discrimination. You have two groups of people who are very similarly situated, people with psychiatric advance directives and people with healthcare advance directives, and you're treating them differently for no clear reason. If there need to be these constitutional protections for people with healthcare advance directives, it needs to be at the same level for people with psychiatric advance directives. And so that's why the case was decided in her favor. And then they had to rework the laws to make the protections equal across the two. I don't think I explicitly said this earlier, but it's kind of implied the psychiatric advance directive was easier to override than the healthcare, the standard one. So sometimes people point to that and they say, oh, look, the courts enforced this advance directive where someone just refused all medication. And so that's not what we want to have happen, is that people do these documents and then no one can give them any medication. And there's a variety of reasons why that concern isn't true. First of all, it wasn't about enforcing that particular advance directive. It was about making it fair between all folks who have advance directives. And the second part on that is that there are tons of limits, as have already been spoken, right? If someone's civilly committed, if someone's committed to the hospital, those are all limits on the enforceability. So those things override the existence of a DMHT. Also, if a provider has a good faith reason and they document that of why it's not in the individual's best interest to enforce their advance directive, or if their representative agrees to something else, those can all be limits on concerns like this. So just wanted to make a note of that in case you hear that case brought up at some point. Also, enforceability is unlikely to be an issue based on what we know about psychiatric advance directives. 94% of them that were analyzed in the study included clinically useful information, and about 91 to 95% were judged as feasible overall by the folks who were reviewing them. And actually, this last study from the 90s was done right here in Oregon by the folks who put out who were involved in the original legislation around providing DMHTs. They surveyed folks who had had one in place, and it appeared that whenever individuals used one, although a very small minority of folks had an opportunity to use theirs, the folks who had, the conditions appear to have been respected in a crisis. So hopefully this is all sort of coming together to make enforceability, much less of an issue and a barrier for folks as they understand all of these components. So I'm going to just talk briefly about a study that I did here in Oregon. I don't think it would have gone out to anyone who's in this training. About half of I sent it out at the state hospital. About half of the participants were folks from the state hospital. I also sent it out to some Oregon, like professional associations, like the Oregon Psychological Association, the Social Work Professional Association in Oregon, and a few others. But basically, we ended up with about 225 folks who went through the whole survey. We had like 450 originally, but so many people dropped off after the first question. So I'll just put a plug for if you ever get an email to do a survey research, please do it. It's super helpful. It helps us understand whatever it is we're sort of researching and studying. But whenever at the beginning of the survey, very few providers were even aware of the existence of DMHTs. Most had misinformation about the basic facts of it. We had some like true false questions to assess knowledge of DMHTs in Oregon. And most indicated they had very little confidence and low perceived ease and usefulness in trying to implement a DMHT. I wrote this vignette in the study where it was like an individual, a young man who had his first psychotic episode, and he was on the Max line in Portland, and he was behaving somewhat bizarrely, ended up drawing the attention of police. I think in the vignette I had him do some damage to some of the Max line, and he ends up getting arrested, and he ends up coming to the state hospital. He's restored to competency, and then he's returned to the community. And once he's back in the community, he and his mom are trying to plan ahead to deal with any future psychiatric crises that may come up. And I asked providers what they would do, right? Before giving them any information about DMHTs, I was like, what would you do in this situation? What would you do to help this family? And this was a really ideal situation for someone to use a DMHT. They had a person, their mother, right there, who could help by being a representative who was willing to help and willing to engage. They were very much trying to plan ahead for a future psychiatric crisis to avoid a coercive outcome of like going to the state hospital again and being arrested. And across the board, we had like very little responses that indicated that people felt effective to be able to handle that. We asked an open-ended question, and reading this open-ended question was heartbreaking. Like all of the responses that we got. Some people were like, there's nothing you can do. You just have to wait until he hurts someone and gets arrested, and then he has to get coerced treatment. It was just incredibly sad. One person said like they should just move to a different state. It was really disheartening to read some of these messages, and I felt very much the hopelessness and frustration that people experienced. So then I did an exceedingly brief educational intervention on the statutes, and I'm talking, it was like one page of like 15 bullet points, right? Like just a very limited, just providing basic information about how DMHTs work. And providers went from low to moderate in their confidence to use a DMHT and help the family. And the increase was predicted by their understanding of the brief educational intervention. So after I presented the bullet points, I had like true false questions that people had to answer. And if they got it wrong, then a little screen popped up and told them the correct answer. And so it was kind of like forcing people to interact with the information before allowing them to go forward to the second part of the post-education quiz. The post-education quiz, although it showed that people were a little bit more confident in their ability to use DMHTs, there was not an increase in their perceived like ease of implementation. And also we only bumped them up to like the moderate range, which implies that there's still a lot more, like one brief educational intervention isn't sufficient. We got to be providing education and helping people understand the resources that are available, and especially addressing pragmatic supports that can be available. So let's see here. Okay. So future directions, as I've mentioned, this has the potential to be hugely impactful for consumers, providers, loved ones, and the general public. We need education, we need ongoing research, we need increased pragmatic support. As Nirmala mentioned earlier, one of the main issues right now is dissemination of the document. And another practical barrier is providing support for people to know about these and complete them. And then another thing that's come up a lot in my conversations with families and individuals who are interested in using these documents is that sometimes transportation can be an issue. So let's say the individual does want treatment of some kind, but their representative would be willing to consent to treatment of some kind, including like hospitalization or stabilization, there may be no way to get the person from point A to point B unless they happen to be willing to hop in the car with their representative and go, which may not always be the case. So transportation, dissemination, completion are all of the sort of areas that we're working to try and address. And if anyone has any ideas, I am all ears. I would love to hear about it. I'm trying to come up with some ideas around here, but it is a bit of a challenge. I think that this has, and obviously I'm coming from a perspective of someone who works in a state hospital, but I think this has a huge ability to get people out of the criminal justice system, right, as a pre-arrest diversion or deflection point, and give law enforcement officers an alternative to an arrest. So I know folks are probably familiar with all of the things that have been going on with the state hospital in terms of it being overcrowded and there being sort of lawsuits that are requiring us to release people at certain time points, whether or not they're ready to be released. But one thing that I think can be really helpful to think about is the more that we as a state build capacity in the state hospital system instead of being able to build it in the community for individuals, then we're creating easier pathways for people to go into that institutional setting as opposed to being able to stay in the community. So something like this is definitely building capacity in the community as opposed to building more capacity at the state hospital. So I hope that idea makes sense. But if only 10 people per year were to be impacted and deflected from the criminal justice system with this intervention, the state hospital runs at about $16.30 per day per person as a rough estimate. And 134 days is the average day for competency restoration based on a meta-analysis, not from Oregon, but from other states. That has the potential to save the state hospital over $2 million every year. And so even just as taxpayers, I hope that is a number that brings up how potentially and makes very concrete how potentially impactful these could be. Noticing I'm running out of time, it's 10:41. So I'm going to move through these other slides a little bit more quickly, but obviously you'll have a copy of the slides and we'll be able to refer back to these things. Also, several of the items in the next few slides are things that Nirmala already touched on. So hopefully it won't be unfamiliar to you. So I think learning and understanding the law and learning and understanding these tools is how you can really become an effective advocate, being sort of fluent in the language of these interventions. But one thing that I'll note is if you've ever had a will executed, the provisions for doing one of these, the two witnesses who you sign it in front of them and all they're attesting to is that you appear to have been of sound mind and didn't appear to be being coerced, that's very similar to how someone implements a will, executes a will, right? And so it's that same kind of legal idea. Although a DMHT can give a representative or the individual, if they put it in their DMHT, admission to and the ability to consent to treatment for up to 17 days in an inpatient facility, it doesn't do anything about funding. So that is still an issue about paying for that hospitalization or paying for these services that you have to keep in mind is where those resources are going to come from. Yeah. So there's an OHA form, and I've got a link to that on my last slide that can be used. And you don't have to use that form, but you do have to make sure all of these components are met. And that form does have all of those components in it, so it's a bit easier to use. So a DMHT can include specific aspects that someone wants or designating you can have both, one or the other. Incapacity is determined by either two physicians agreeing or by a court proceeding. Right. And once delivered, it's supposed to be stored as part of the person's medical record, depending on the situation. So like the Joint Commission and CMS, they all have regulations and requirements about how hospitals are supposed to, or anyone who bills to Medicare and Medicaid are supposed to store and refer to these, to any type of advance directive. So that's good to know, to be familiar with in case this is something that your organization or agency is going to put into place. Let's see. Providers can withdraw if there's any concern. Commitment to OSH or civil commitment overrides them. A person who does not administer the DMHT in good faith cannot be subject to criminal prosecution, civil liability, or professional disciplinary action or a person who does or doesn't, if the DMHT proves invalid. So for example, let's say after the fact, it comes out that the representative signed as a witness, and so it's technically invalid. No one's going to get in trouble for having relied on the document for that. And it can't be a requirement for any reason to be completed for any of these reasons. So technically, all healthcare organizations are required under the law to have written policies and procedures about how they provide information to the folks they serve about mental health treatment decisions, including their right to accept or refuse and their right to use a DMHT. Now, again, this is another area where the statute just doesn't have a ton of enforceability or a lot of teeth. An institution can't be subjected to criminal prosecution or civil liability for not complying with that. However, it does sometimes help get agencies on board that otherwise might be reticent. So at the hospital, whenever we highlighted this fact, it did help us get a toolkit together and a technical, like a consultative service that we use to help people who are interested in putting one of these together. So our toolkit includes the OHA form. It includes a lot of information about the hospital's policies. It includes an FAQ for consumers and for providers at the hospital about how these are used. And it includes a flow chart that highlights what the hospital's policy is about when these documents are offered to people and when people are given information about them. And they're supposed to be offered at admission and at discharge, and then every 30 days in between is how we've done it there. Unless there's a documented reason not to. So if the person has like said, I'm definitely not interested, people don't have to keep offering it to them. It's important to provide the information without making recommendations and then to document it in a prominent place so that people know that it exists. One note is along the lines of dissemination, there is in Oregon technically a medical mental health database that's tied to the law enforcement data system, the LEDS system. So people could voluntarily choose to have their information put in that system if they would like, officially under the law. But what we found is that it's really hard. Like this is basically defunct. We can't find a way to make this work. My colleague who did the research with me and who's done some of these trainings with me in the past, and actually I should have thanked her. Her name's Erica Leeper, and she put together some of these slides on the Oregon Revised Statutes. She tried very hard to find someone to talk to about this medical mental health database. And we found one person's name, but that person had retired. And then we like tried to follow up on that, and we just like couldn't get responses. I don't know if this is revivable, but it's technically exists, and but it's very difficult to try and use it. Here are the links with information about that and what the form contains that is an option for people if they want to use it, if they want for law enforcement to have that information. Here are some resources. The first link is a podcast that Dr. Leeper and I did after we did our research a couple years ago that I spoke about earlier. And that podcast was with Gobi. And so if you're interested or suffering from insomnia, you can check out the podcast. It's got some more information in it. The second link is the National Resource Center on Psychiatric Advance Directives. which has some helpful information. It also has some state-by-state information, but I will note that they are often slow to update things. So I know for a fact that there are some changes in state law that aren't reflected on the website currently. So I would just encourage you to double check the information that you have there. I also had the SAMHSA practical guide in my resources list. And then the last link there is the OHA form that's available for review. And the last thing that I'll touch on is starting the conversation, right? So ideally, the first step is to familiarize yourself with the research, the law, and the available resources so that you're fluent in what's available. And congratulations, hopefully that's done now after this training. The next thing would be to implement the ORS that requires written policies for your organization about how and when information about DMHTs is already happening. Like I said, at the hospital, we built it into intake and discharge, and then interdisciplinary treatment team meetings in between. Follow those policies, always a good start. And then look for openings for additional discussions. So if you're familiar with the outcomes or with the power of a DMHT and you're talking with someone and you hear them say something like, man, I really wish that I could know I'm not going to get arrested again in the middle of a psychiatric crisis, but I'm going to get taken to a hospital. And you're like, boy, do I have the intervention for you? So being fluent in this can provide that opportunity to bring it up without necessarily making a sort of a big deal about it. If you ever have the opportunity to make recommendations, if you're writing treatment plans or if you're making recommendations back to the interdisciplinary treatment team, if it's appropriate, include this information. I have a blurb that I use in all of my reports in the hospital when it's appropriate that helps direct people to the hospital's toolkit and to the consultative service, and that explains briefly what a DMHT is. So offer support for people who are attempting to complete one. Remember that research earlier about people are more likely to have them in place if someone is there to help them complete it. And problem solve in advance with the individual. So try to help them identify how they want to disseminate the document. When do they want to update it since it's going to expire in 3 years? And what would they like to do about transportation? And so having that conversation with the individual and their representative, if they have one, can be really helpful. So that's it. Thank you.
Wow. Wow. Lots of great information. My colleague Angela, would you like to jump in there and help us wrap up? We're going to take questions first.
Yeah, if anyone has any questions, go ahead and unmute yourself or put it in the chat.
Actually, I had put a question. Hi, this is Nirmala, Andrea, but you answered it in your last slide. I said, do you routinely put that as a recommendation in your forensic assessments at the state hospital? My second question as a follow-up would be, I don't know how long you have been doing that at the state hospital. Any kind of longitudinal data that how many people actually went on to get one, Yeah, so
it's did I interrupt you? I was just going to say I've been doing it for a few years and basically none so far. So again, we find that people like these ideas, but that it's hard to get traction on it. So one of the things that we're working on is trying to make this more present and easier for people to do at the hospital, but that's definitely a work in progress.
Right. We saw that also initially in advanced care directives, where we have such a big taboo on death and dying in our culture that people were not comfortable completing it. And so, I know all of us through our initiative are working on kind of, addressing that, through death cafes, etc., where we talk about death and dying. So I'm wondering if there's also like a degree of fear or, stigma, to actually, so I'm just curious, what are some barriers that, 20, 30 years later, the uptake is still so low?
I'm sorry, can you repeat part of that question? I got distracted by the questions in the chat. I'm so sorry.
No, I was just saying, why after 30 years, the uptake of this intervention is still fairly low.
So
yeah.
I'm sorry. I'm sorry. At the end of 2 hours, I'm sure, like everybody else, my attention is starting to fail me a bit. One of my colleagues and friends, Heather Zell, along with Kathleen Kemp, and I want to say there were a couple of other authors, they tried so hard in Virginia, probably about 10 years ago, to get this off the ground. Like, they had grant money, they spent a tremendous amount of time and effort trying to do that. And they wrote an article about it, about all the ways in which it failed. And so if you want to see a postmortem that's really well done, in Virginia, you can take a look at that. But basically, I think there's just there's a lot of hesitancy around it from providers. And unfortunately, I think that hesitancy often reflects stigmatization of people with SMI, because a lot of times whenever I'm providing this education, the question that I get is like, well, basically it's, what if they make a decision I don't agree with? Or what if they make a decision that I don't approve of, which really isn't the point of these documents. First of all, that concern is not borne out by the research, but even if it was, the point of these interventions is to give power back to the people who are facing coercive treatment and involuntary treatment, and to help them plan in advance for what they want. And so I think always coming back to that recovery orientation and that self-determination aspect of it is really important.
So which system do you think would be able to make the biggest impact? Would it be PCPs, the medical side, as they're seeing these patients, clients that come through the door, and there's a gap that they can plug? Or is it at the hospital when somebody has been stabilized from crisis, of let's get this taken care of? I mean, you said that it requires witnesses. So if you're in a crisis, chances are you're not going to have two people there that can serve as witnesses.
But Angela, you wouldn't write it in a crisis. So,
Right. But if you are getting somebody restored, and we know that some of our folks are at the hospital for a while, for whatever reason. Yeah. So, and when I say hospital, I mean like your local ED department, and then somebody might actually be housed in the ED for a while, or go up to a med surg floor. So is there one system that might have better luck in pressing in on these?
I mean, I do think that the state hospital has a unique role to play, because we are serving the population of folks who are most likely to need one of these in the future, right? Like, we have a concentration of that population at the state hospital. And I really think like first responders, like cahoots, and law officers, like if they were folks who were like, we would really like for people to have these, like we're on board, we'll enforce them, we'll take them where they want to go. Like, I think if there was that support at that point of contact, that could be really helpful and beneficial. But I mean, really, ideally, every single person in the state would at least understand that this is an option they could have if they want. Just like everyone sort of generally knows you could have a will, or you could have a healthcare power of attorney. But I think having these just be part of the like vernacular around mental health treatment is something that could be really powerful. And then really quickly, I noticed someone in the chats asked about a link to the toolkit. As Angela Franklin noted, the toolkit is specific to the state hospital, so it's not going to be helpful to other people. Like our flow chart and the hospital's policies aren't necessarily going to be helpful to other people. But the things that we have in the toolkit that are generally accessible, like the OHA form, those are all included in this training. Ideally, at some point, we would develop a similar toolkit that would be available to our partners in the community, which we would obviously give to anyone who they wanted. But that is something that's still sort of pending. So hopefully soon.
I'd like to add to what Andrea said. I think the organizations with the greatest influence to facilitate a collaborative, development would be community mental health programs, where we have long relationships. I worked for 20 years where I knew people for 20 years, and I had built a collaborative, trusting relationship with the client, with the family members. So I think we'll get the most bang for our buck from really working with community mental health programs, where the majority of people with serious mental illness are served because of the more comprehensive wraparound services, which, private practice and primary care teams are unable to provide. And they don't have that kind of deep, long, in my opinion, therapeutic relationship. So if I was to strategize now, I would look at, how do we raise the awareness and education of options for Southern Oregon? The Angelas, y'all represent that, and many other places. How do we get that message out to them? Then also Andrea referred to deflection programs. They're in the making. How do we get there on the ground floor?
Expect some more invitations to speak at county mental health systems. I think you've just opened that door, Nirmala. You just created more work for yourself. We are grateful that you are willing to spread the word. And Dr. Avila, same for you. Well, folks, we have come to the end of our time, and I just want to check in with my colleague, the other Angela. Angela, would you like to wrap things up for us?
I believe, can you see the slide that's up on the?
I can.
Okay. So we want to just thank Nirmala and Andrea on presenting on this. We know that this is something that has not been addressed or really put out there in education for quite some time. So I'm kind of excited, as this might be a little bit of the first that at least the Older Adult Behavioral Health Initiative is going to be putting more energy towards and in collaboration with our partners around the state. So you will receive an email with our surveys and the training materials, and we will include the most recent updated DMHT guide and the form within that. So you'll have that most recent one that was updated in 2014, I think. And then you can receive a certificate of attendance, or if you want to get the CEUs, make sure you do that extra survey. And yeah, we just really appreciate everyone for coming. If you have any questions, please email Nirmala, Andrea, or myself, and we will get back to you as quick as we can. So farewell and have a good day.
Bye, everybody. We will see you in the fall unless otherwise notified.